Welcome to the third day of USMLE Workshop 2009. Today I'm proudly to invite Professor Kritvikom Durong-Pisitgun, Associate Dean for Faculty of Medicine, Mahidol University, to be our moderator in morning session.
Good morning, everybody, and welcome. This is the third day for the workshop. I'm very delighted to have a speaker here today, Dr. Wanpen Vongpatanasin. She's now Associate Professor at the Division of Cardiology at University of Texas Southwestern Medical Center. I remember Dr. Wanpen and me started to going, and at the time it's called FMGAMS. Not the USMLE. By the time when we took the examination and get into the matching, we are entering pretty much at the same year, going to United States. And I did recall that she have a very nice paper on reviewing on the heart valve processes in the New England Journal of Medicine. Ladies and gentlemen, please join me. Welcome Dr. Wanpen. Please.
Thank you, Dr. Kritvikom, for a kind introduction. So I think that since this is a preparation for the use mouse, I think we should do everything in English so that you can practice to take the exam and also interview for the residency program as well. So we're going to go through questions, but feel free to raise your hand and ask the question anytime. And from time to time, we're going to have a power vote. So that's a good way to review whether how much you know. But I think I did it about 2 years ago, and it seems like everyone's very knowledgeable about the test. Maybe at the end, a couple people start to fall asleep. But anyway. All right, so we're going to start with the... Okay, good. So the first question, it's a 50-year-old woman present with a chief complaint of dizziness when she get out of bed in the morning. During the episode of dizziness, she feels very warm and flushed. She admits to frequent episodes of abdominal cramping and severe watery diarrhea during the past year and began to have dry, itchy skin. On physical exam, she has a 206 systolic murmur, best heard at the left lower sternal border, no wheezing, rhonchi, or crackles on apparent lung examination. Laboratory results are unremarkable. Which of the following is the most appropriate next step in diagnosis? A, barium examination of the bowel. B, measurement of serum lipase and amylase. C, ultrasound abdomen. D, urinalysis for 5-HIAA, or E, small bowel biopsy. Call power vote. Okay. It's kind of spread out, but let's. So actually, this patient has the episode of flushing. That's kind of key word, and also has a murmur that actually could be consistent with tricuspid regurgitation. And actually, she has. Trying to advance the slide. She actually had carcinoid syndrome. And the diagnosis requires measurement of urine for 5-hydroxyindocytic acid. So carcinoid tumor is a neuroendocrine tumor which releases serotonin. And serotonin usually is metabolized by the liver. And the combination flushing, diarrhea, and liver metastasis, it's part of what we call carcinoid syndrome. And usually the serotonin metabolite causes valvular fibrosis. And because usually it's on the liver, it's deposited on the right side right side of heart. So it can cause tricuspid regurgitation, stenosis. pulmonic stenosis or regurgitation and right-sided heart failure. And the differential diagnosis require something other than carcinoid mastocytosis, which can mimic carcinoid syndrome, but they usually don't have valvular heart disease. Second question, 30-year-old man present to the emergency room department with severe headaches, visual changes and palpitations. His temperature is 100 Fahrenheit, but blood pressure 190 or 130 millimeter, mercury pulse of 130, respiration 17 per minute. The rest of physical exam is unremarkable except for clampiness of the hands and increased sweating on the face. Patient hypertension is treated. 24 urine specimens show elevated methanephrine, VMA, and HVA. Upon questioning, patient notes that the endocrine problem is very frequent in his family. This patient is most likely at significant risk for developing which of the following thyroid diseases. A, grave disease, 2, Hashimoto thyroiditis, C, medullary carcinoma, D, multinodular goiter, or E, papillary carcinoma. Let's do the vote on that one too. Power vote,เลยค่ะ All right, good. So everyone knows. So what is this part of the syndrome? What is it called? Say again. So next slide. Good. So it's part of the, so this patient presents with the typical pheochromocytoma, which can be a familial kind of syndrome. And the familial syndrome, the associated pheochromocytoma, could be MEN2A or MEN2B. MEN2A is the associated with medullary thyroid carcinoma, pheochromocytoma, and 50%, and hyperparathyroidism. MEN2B also associated pheochromocytoma in half of the time, medullary thyroid carcinoma, and instead of having hyperparathyroid, they have mucosal neuroma. And von Hippel-Lindau, about a quarter of the patient have pheochromocytoma, but they can also have retinal angioma and cerebellar hemangioblastoma and renal cell carcinoma. Neurofibromatosis also associated pheo, but it's only in 5% of the time. Next question, a 39-year-old man presents to emergency department with new onset of shortness of breath, hemoptysis, and left-sided pleuritic chest pain. Past medical history concludes medication control, asthma, peptic ulcer disease, and recent onset of nephrotic syndrome. His blood pressure is high, 180 or 100, and pulse of 110. He's breathing fast, 28 per minute. Chest and lung exam are normal. Laboratory data remarkable for serum LDH of 300 units per liter. And ECG show sinus tachycardia and prominent S wave in lead 1, inversion of T waves, and prominent Q waves in lead 3. Which of the following is most likely the cause of chest pain? You can just yell it out. What do you think is the cause of chest pain in this patient? We don't have to do power vote. If you want to do power vote? Okay, all right, let's do it. Go ahead. Vote, have you? Okay, I guess most people know. So this is the pulmonary embolism rather than myocardial infarction, even though that's a Q wave. But the pattern of S1 in S in lead 1, T inversion in lead 3, and Q in 3. In a person who have risk factor for thromboembolic events. But with nephrotic syndrome, you can lose antithrombin 3, and you can have increased coagulability, coagulable state. So that's the right answer is E. Okay. So that's just to show that the parent of the S in 1, lead 1, T-wave inversion in 3, and isolate Q-wave in 3 is consistent with the PE. But it's more specific, but it's not very common, only 20 to 30% of the time. Sinus tachycardia is more common, but obviously it's not specific. Okay, the next question is 47-year-old Brazilian immigrant with complaints of fatigue and dyspnea. He's been healthy for the past 10 years, denies fever, cough, chills, or weight loss. On exam, there are no murmurs, and the pulse and rhythm are regular. S1 is normal, S2 is split. This split increase with inspiration, persists with expiration. Which of the following ECG findings is most consistent with the auscultatory finding of this patient? A, acute ST elevation in anterior leads. B, decrease in PR interval. E, early repolarization. D, marked T-wave inversion. And E, right bundle branch block. It's a little harder because it's not a kind of problem that we found in these countries, but so it's good practice to know. All right, you got it anyway. So this patient actually have right bundle branch block from Chagas disease, which is trypanosomiasis, which is found more commonly in the South Americans. This patient is coming from Brazil, so that's usually associated with the right bundle branch block. And the physical exam sort of suggests the increase in right ventricular ejection time with the Y split S2. So it's caused by trypanosoma cruzi and transmitted by triatomine barcode blood transfusion. And initial phase is only a mild febrile illness, but the chronic phase that's when patients start to have heart failure, arrhythmia. They can have thromboembolism from LV aneurysm or syncope. And EKG findings is you can find right bundle branch block, left anterior fascicular block, ventricular tachycardia, AV block. Next question is due to recent sudden death of a rival college football player, a local university wished to implement changes in healthcare policy. The school is particularly concerned about the risk of sudden cardiac death in the players with previously undiagnosed heart conditions. A pre-participation evaluation is to be performed on all of the school athletes. Which of the following is considered the most cost-effective method of screening young athletes at risk for sudden cardiac death? A, careful medical history and examination. B, chest X-ray. C, echocardiography. D, exercise electrocardiography. Or E, resting ECG. ขอโหวตเลยค่ะ Okay, so it's kind of split down. It's a relatively tricky question because remember this is an exam that was given by the U.S. Group, so it reflects the healthcare policy in the United States. So we need to know what is the common cause of sudden death in the young athlete in the country. And but anyway, let's see. So the answer is the careful medical history and examination, not the test. So this actually can get you a lot. And that's based on the most recent guidelines by the American College of Cardiology and American Heart Association. If you ask people in Italy, they probably tell you echo or EKG, but in the United States, the class 1, which is a general agreement, that procedure is useful. It's still pre-participation history and physical examination, including family history of premature sudden cardiac death, and specific evidence of cardiovascular diseases such as cardiomyopathies and ion channel abnormalities. The EKG and echocardiography may be useful, but it's still considered to be class 2B indication, so it's still not agreed upon the expert. That's probably because of the most common cause is the hypertrophic cardiomyopathy, and the people in the consensus still feel like that history and physical examination should be the first to start with. Okay, 20-year-old male college student is participating in the New York City Marathon and collapsed 1/3 of the way through the race. He's a well-developed, athletic man who frequently plays basketball and tennis. He has no medical history except for tonsillectomy 9 years ago. There was no symptoms before he collapsed to the ground or lost consciousness. The patient is immediately rushed to the nearest emergency room, but is pronounced death on arrival. Which of the following is the most likely underlying cause of his sudden death? A, aortic stenosis. B, arrhythmogenic right ventricular dysplasia. C, coronary anomalies. D, hypertrophic cardiomyopathy. E, isolated left ventricular hypertrophy. Or F, myocarditis. Vote เลยค่ะ บอกคำตอบไปแล้ว Okay, that's right. So most people get it right, about 50%. So it's the hypertrophic cardiomyopathy is the right answer. So just to review, causing sudden cardiac death, about 36%, about a third coming from HOCM, hypertrophic cardiomyopathy. The second most common cause is the coronary anomalies. If the right or left coronary artery comes out from the wrong cusp and travel between pulmonary artery and aorta, it can cause sudden death as well. And other than that, it's myocarditis, arrhythmogenic right ventricular dysplasia about 4% of the time. And other things are miscellaneous causes. Next question, 67-year-old man comes to the physician because of insomnia, irritability, palpitation for 3 months. He's currently taking amiodarone for cardiac arrhythmia, fluoxetine for depression, enalapril for hypertension. His blood pressure is 130 with 70, his pulse is 90 and regular. Which of the following is the most appropriate next step? A, measurement of thyroxine and TSH. B, administration of propranolol. C, referral for psychiatric condition. D, substitution of antidepressant. Or E, substitution of antihypertensive drug. Okay. นี่อยากจะโหวตไปเรื่อยๆใช่ไหมหรือว่าโอเคโหวต Okay, good. Most people got it right. So this patient has symptoms of hyperthyroidism. In the presence of amiodarone, you should think about measurement of thyroxine TSH. Let's see. So the answer is A. So the side effects of amiodarone, there's more hypothyroidism is more common, about 20%, but about 3% of the time could be hyperthyroidism. And 15% of patients might have liver problems. 25 skin problem is very common, up to 75%. And neurologic complication occur in about 30%, including peripheral neuropathy. Pulmonary toxicity is the most deadly complication, but it's rare. And the corneal deposit is very common. Everyone, if you take it for a while, will have corneal deposit, but actually it doesn't cause any eye problem. But the one that can cause eye problem, obviously, is optic neuritis, but it's more rare. Question number 8. A 40-year-old woman comes to physician because of 6-month history of increasing respiratory difficulty that occurs during a mild exercise, such as walking uphill. She's 165 centimeter tall, weight 58 kilos, but say that she's lost 4 kilograms over the past 3 months. Her blood pressure is 120/75, pulse of 85, respirations are 16 per minute. Chest exam reveals crackles at both lung bases and a diastolic murmur near the cardiac apex. The characteristic of the murmur change with patient's position. Echocardiography reveals a solid mass that partially fills the left atrium and results in obstruction of the mitral flow. Which of the following is the most likely diagnosis? A, fibroelastoma, B, metastasis, C, mural thrombus, D, myxoma, or E, sarcoma. โหวตเลยค่ะ All right, it's too easy. So actually, so this is the key in the physical finding is the murmur of mitral stenosis, the change with position, and that's because of cardiac myxoma, which usually it's a benign tumor that is common and originate from the septum of the left atrium. And the tumor usually can plop into the mitral valve and cause variable obstruction of mitral valve depending on position of the patient. There's more other rare complication that this patient has, as they might have a weight loss, hemoptysis, or fever of unknown origin from release of interleukin-6, thromboembolism, and it could be associated with the skin manifestation and part of the name. That's several syndrome associated with cardiac myxoma, such as the Lamb syndrome. Okay, next question. 47-year-old woman comes to physician because she has several episodes of chest pain that awoke her in early morning. She has no history of major physical illness or drug abuse, drinks alcohol very occasionally, and does not smoke. Her temperature is 37. Blood pressure is normal, 126/78, pulse of 78 per minute. Respiration is normal, 12. ECG show no abnormalities, no further study undertaken, and the physician tells the patient that her pain is probably of psychological origin. After a few days, patient come to emergency department at 5 in the morning complaining of chest pain. ECG shows sinus rhythm with ST elevation. Patient is admitted and corneal angiography is performed, revealing no stenotic lesions. Intravenous administration of agonavine during angiogram triggers chest pain, which is accompanied by ST elevation and the EKG. Which of the following is the most likely diagnosis? Vorlika. Okay, everyone got, most 75 got it right. So that's right, this is the princemetal angina, which is a coronary vasospasm. So unlike the obstructive coronary artery disease, which the pain usually occur during exertion, this usually occur in early morning hours. And most of the time there's no obstructive coronary artery disease. The diagnosis requires some provocative tests, although actually organovin is no longer available in the United States, but there's some other maneuvers that can provoke the coronary vasospasm. So it's a chest pain that resembles coronary ischemia that occur mainly in the early morning hours. And EKG show ST elevation, just like ST elevation MRI. And if you can't do organovin, you can do hyperventilation. And the treatment requires vasodilators such as nitroglycerin calcium channel blocker or alpha blocker. Try to avoid using beta blocker alone, which is opposite from obstructive coronary artery disease, because it can aggravate and oppose alpha-adrenergic mediated vasoconstriction. So pure beta blocker is not advisable for this condition. Question number 10. 20-year-old man is brought by his roommate to the emergency department because of abrupt onset of chest pain, shortness of breath, mild chest pain, and sensation of rapid heartbeat. Patients say that in the past he has similar episode which resolved with Valsalva maneuver on breath holding. At this time, these maneuvers were unsuccessful. He does not take any medication and is otherwise in good health. ECG documents supraventricular tachycardia with a pulse of 200 per minute. Under the ECG monitoring, a gentle massage of the right carotid sinus is attempted, but the tach does not cease. Which of the following is the most appropriate next step in the treatment? That's the right answer. So this patient has SVT with a stable blood pressure, or at least there's nothing to mention that he lost conscious or become more unstable. So he's already failed carotid sinus massage. Doing some more is not going to be helpful. IV lidocaine is not helpful in this setting. Procainamide, it can accelerate the atrial conduction rate and increasing the SVT rate. So it has to be given after you use AV nodal blocking agent. So it's either D or E, but it's in the acute setting. You don't want to wait forever for the oral drug to start to work. So usually the first choice is adenosine because of the short half-life, but there's no adenosine in here, so you should use D, IV verapamil. So next question is 38-year-old woman who's complaining of shortness of breath that starts suddenly on the morning of presentation. She's otherwise healthy, takes oral contraceptive pills. She has 10-year history of smoking, a pack of cigarettes daily. She appears anxious and is breathing rapidly at 30 breaths per minute. Her pulse is, she's tachycardic, 110 beats per minute. Her blood pressure is still stable, 120 or 80. The rest of physical examination is unremarkable. Which of the following is the most appropriate initial step in management? A, aspirin, B, Coumadin, C, heparin, D, IV fluid, or E, streptokinase. Okay, it's still a little spread out. So the majority of people get it right. So this patient has acute pulmonary embolism from taking oral contraceptives, and she's a little bit older. Anyone who's older than 35 should not, who's taking oral contraceptives should not smoke. But it's a risk factor for acute pulmonary embolism. In the acute setting, you should start heparin first. So just to review the management of acute pulmonary embolism, you just should think about whether you should start heparin and determine if the patient is the high risk or not high risk. The high risk is defined by if the patient has low blood pressure or evidence of right ventricular dysfunction by echocardiography. If patient is not at high risk, at least in this patient, they didn't indicate that she has low blood pressure. You should start with anticoagulation after the heparin, starting a Coumadin or warfarin with the INR between 2 to 3. And if this is pulmonary embolism has a precipitating factors like surgery or trauma, you can stop it after 6 months. But if it's idiopathic, that's should think about consider indefinite duration of anticoagulation. For those who's at high risk, you should think about thrombolysis with streptokinase or TPA and embolectomy in some center that has the capability of doing that. Question number 12. 45-year-old man presents to a physician because of repeated episodes of fainting. The radial pulse is erratic with multiple skip beats at the rate of 45 beats per minute. And ECG show normal sinus rhythm at 60 beats per minute. Echocardiogram show 2 centimeter mass acting like a ball valve, producing intermittent obstruction of the flow. Which of the following is the most likely location of patient's lesion? Aorta, B left atrium, C left ventricle, C right atrium, or E right ventricle? Okay, so we talked about this condition a little bit on a couple of slides ago. So this patient has most likely have cardiac myxoma, and the mass is acting like a cause intermittent obstruction of the mitral valve. And most likely location is of this cardiac myxoma usually happen in the left atrium. So the answer is B. So next question is a 64-year-old man is brought to the emergency department because of sudden onset of tearing chest pain that seems to originate from the anterior chest and radiating to the back in the interscapular region. A few weeks ago, he has dental abscess, which resolved with extraction followed by a full course of ampicillin. On examination, he's oriented to the person, place, and time, but he appears in acute distress, diaphoretic, and is breathing with difficulty. His blood pressure, his temperature is 37.1, blood pressure 174/68, pulse of 206. So he's really tachycardic. He's breathing relatively fast, 25 beats per minute. There's no jugular venous distension or hepatomegaly. Auscultation show diastolic murmur along the left sternal border. Lungs are clear on auscultation. ECG show no signs of myocardial ischemia. And chest X-ray show widening of mediastinum. Which of the following is the most likely diagnosis? A, aortic dissection, B, acute mediastinitis, C, acute pericarditis, D, cardiac tamponade, or E, myocardial infarction. Voteเลยค่ะ So everyone, good, as most people get it right. So aortic dissection usually have a quality of tearing type of chest pain, and patient could have a murmur of aortic regurgitation if it dissected back to at the root. And the chest X-ray, I think that's the one that gives away diagnosis, widening of mediastinum. So the answer is A. Okay, I think I'm going to skip this one. Okay, we can talk about this one. A 72-year-old man suffers from severe pruritic chest pain on the 7th post-operative day after surgical pinning of the intertrochanteric hip fracture. He was not on anticoagulants at the time. He's hemodynamically stable, but is short of breath, and it has distended neck veins. Spiral chest CT show presence of pulmonary embolism on the left side, and echocardiogram does not show signs of right ventricular strain. Which of the following is the most appropriate management at this time? A, anticoagulation with heparin. B, infusion of thrombolytic agents in the left pulmonary artery. C, insertion of vena cava filter. D, surgical embolectomy. E, systemic infusion of thrombolytic agents. Voteเลยค่ะ Okay, most of people get it right. So in this patient, we talked about that you should, when your patient has PE, you should think about whether the patient is high risk or not high risk. But this patient doesn't look like has high risk features. Blood pressure is not, there's no mentioning his blood pressure is low. Hemodynamically is stable. So there's no need to give thrombolytic agents or do surgical embolectomy. The issue about heparin is that whether a patient who had surgery, whether the surgeon feel like anticoagulation will be safe. But this patient is already 7 days post-operatively. Usually the bleeding risk is already low at that point. So vena cava filter, sometimes we place it in people who has recurrent pulmonary embolism and has contraindication for Coumadin. But at this point, there's nothing to say that this patient has contraindication for anticoagulation yet. So I think that heparin would still be appropriate choice. So let's see. Okay, let's talk about this one. A previously healthy 22-year-old man comes to medical attention because of progressive exertional dyspnea, punctuated by episodes of precordial chest pain. Patient's father and his elder sibling died of chronic heart disease in the middle age. The most significant findings on physical examination include presence of loud S4 and a harsh systolic murmur. The latter increases with the Valsalva maneuver and decreases with squatting. Bibasilar rows are heard on lung auscultation. Blood pressure, pulse, and respiratory rates are within normal limits. A chest X-ray film show no appreciable alteration of cardiac silhouette, but the ECG show left axis deviation. Echocardiography show marked thickening of interventricular septum associated with delayed relaxation and filling of the left ventricle during diastole. Which of the following is the most appropriate initial step? A, beta blocker, B, digitalis, C, long-acting nitrates, D, aortic valve replacement, or E, partial excision of the myocardial septum. Vote like that. Okay, most people get it right. So this patient has hypertrophic cardiomyopathy, and usually you should try to give medication that decrease contractility and minimize the obstruction in left ventricular outflow tract. And the drug that usually is initial management is beta blocker. Digitalis increase contractility. It actually make the obstruction worse. Any kind of vasodilator can reduce the preload and can make the a dynamic obstruction of left ventricular outflow tract worse as well, so you should avoid long-acting nitrates. Aortic valve replacement is not going to be helpful because that's not where the problem is. People who still have symptoms despite beta blocker might consider to have septal myectomy, or now there's more newer procedure that can be done percutaneously with embolization to cause the limited infarction of the septum. That's an alternative for surgical myectomy as well. So the answer is A. So as we talked about, it can have cardiac, it could be a familial disease, and usually it's a mutation in cardiac sarcomere, and that causes the asymmetric, this is interventricular septum, this is a free wall. There's a marked hypertrophy in interventricular septum. This is right ventricle, which is tiny, but you can see that it impinges on the left ventricular outflow tract and causes this part to be narrow. And usually the treatment requires beta blocker, verapamil, and avoid volume depletion nitrates or inotropic agents. And you can treatment, when people fail this drug, you should think about septal myectomy and the excise part of the interventricular septum, or septum ablation with the alcohol, percutaneous alcohol injection. Next question is 34-year-old woman who's referred by an OB-GYN colleagues for the onset of fatigue and dyspnea. On exertion for 1 month after the second vaginal delivery, physical examination showed laterally displaced PMI, elevated jugular venous pressure, and 2+ pitting edema, and echocardiography shows systolic dysfunction with ejection fraction of 30%. Which of the statements most accurately describe her condition? A, the disease may occur unexpectedly years after pregnancy and delivery. B, about half of the similar patients will recover completely. C, condition is idiosyncratic. The risk of recurrence with future pregnancy is no greater than average. Or D, this condition will require different therapeutic approach than typical dilated cardiomyopathy. Or E, this condition will require endomyocardial biopsy for diagnosis. Okay, it's a little bit more spread out, but most people get it right. So this is what this patient has: peripartum cardiomyopathy, and so the disease actually about 30 to 50% of the time the patient will recover completely, and usually peripartum cardiomyopathy occurs in the last trimester of pregnancy up until 6 weeks after delivery. The cause is still unknown. It could be a myocarditis that was triggered by viral infection, and about 1/3 to 1/2 recover left ventricular function completely over 6 to 12 months. And recurrence, the heart failure is common depending on whether the heart function recover completely or not. If the heart function recovers completely, the chance of having heart failure with subsequent pregnancy is 20%. But if patient continues to have persistently abnormal ventricular function of up to 40%, will have recurrent heart failure with subsequent pregnancy, and that carry very, very high mortality rate of 25%. The treatment is actually not usually different from the usual heart failure. Okay, we can talk about this one. 46-year-old woman complains of dyspnea on exertion and orthopnea that started 7 months ago. She has prior history of cardiac pericarditis, which has been treated with indomethacin. ECG showed low voltage in the limb leads. Chest X-ray showed pericardial calcification. Echocardiogram showed pericardial thickening. Cardiac catheterization shows equal pressures in the 4 cardiac chambers. During diastole, with all pressures elevated, which of the following findings on physical examination would be consistent with diagnosis of constrictive pericarditis? A, increased vein distension on inspiration. B, exaggerated first and second heart sounds. C, extra third heart sound. D, extra fourth heart sounds. Or E, predominance of left-sided symptoms over right-sided symptoms. โหวตเลยค่ะ Okay, about only 16 people voted. Wow, okay. So actually, the most people get it right. It's the increased neck vein distension. So this patient has constrictive pericarditis, the physical examination that goes along with constrictive pericarditis is increased neck vein distension with inspiration. So the answer is A. The signs of constrictive pericarditis is elevated jugular venous pressure with rapidly collapsing Y descent because there's no limited room for fill in early diastole. But the sign that we talked about, the increase in jugular venous pressure with inspiration, is called Kussmaul's sign. Usually S3 or S4 is not the signs of pericarditis, constrictive pericarditis, but you can have pericardial knock, which is a low-frequency diastolic sound. And patients usually have predominant right-sided heart failure presentation and left heart failure. Particularly, they might have hepatomegaly ascites and lower extremity edema. So that's we should know about. Okay, next question. Okay. 72-year-old man presents with a chief complaint of 3 episodes of fainting over the past month. He also related several episodes of left-sided chest pain that occur with exertion and resolve with rest. He noticed increased leg edema and orthopnea, no prior cardiac history, and he's not on any medication. His blood pressure is okay, 130 with 70. His pulse is normal, 70 beats per minute. Lower extremity edema is present in both legs. Carotid upstroke is delayed. Cardiac exam is remarkable for S1 and soft single S2. Patient has late peaking systolic ejection murmur at the right upper sternal border. And ECG shows signs of left ventricular hypertrophy. Which of the following is the most likely diagnosis? A, aortic insufficiency. B, aortic stenosis. C, mitral insufficiency. D, mitral stenosis. Or E, tricuspid insufficiency. โหวตเลยค่ะ พูดไปเรื่อยถึง10 โมงเช้านะ Okay. Okay, good. People start to wake up again. So aortic stenosis is the right answer because this is an elderly patient who's have the symptoms of heart failure and syncope and chest pain and the murmur, the late peaking systolic murmurs and the delayed carotid upstroke is consistent with severe AS and ECG finding that goes along with it. So that's the right answer. Okay. Next question is 55-year-old white man who was admitted to the hospital for chest pain, and you're asking to rule out MI plus assess for underlying coronary artery disease. Patient tends to be anxious about his health. On examination, the lung will clear. His heart reveals a grade 106 systolic murmur. at the left upper sternal border without radiation. Blood pressure readings have been consistently high, 140, 190 to 150, 100. Cardiac enzymes are normal. Resting EKG show only left ventricular hypertrophy with a secondary STT changes. Why would the treadmill ECG test not an appropriate test in this patient? A, anticipated difficulty with the patient's anxiety. B, increased risk associated with blood pressure readings. C, concern about the heart murmur. That's relatively contraindication for the stress test. D, presence of left ventricular hypertrophy with STT changes on baseline ECG. Or E, concern that this represents the onset of unstable angina with unacceptable risk of myocardial infarction during the test บทเลยค่ะ นี่ไปเร็วเกินไปหรือพอดีเร็วเกินไปเหรอไม่เร็วโอเค Okay, well, actually not, we can talk about that a little bit more. So this patient didn't really have a chest pain during the test or immediately before. So the right answer is D. And the presence of left ventricular hypertrophy with baseline ECG changes, during the test, you can have more ST depression, and it could be just a normal response in the presence of hypertension with left ventricular hypertrophy. So it could carry a lot of false positive tests that you don't know what it means. So usually you should combine it with some sort of imaging modalities like a perfusion, nuclear imaging studies, or echocardiogram. So just to quickly review the guidelines for treadmill tests, the absolute contraindication, obviously the acute myocardial infarction, high-risk unstable angina, but this patient doesn't really have unstable angina, uncontrolled arrhythmia, severe symptomatic aortic stenosis. But if you have severe AS alone without symptoms, it's not a contraindication because patients still going to have to run and catch the bus during the daily routine. So if you want to find out if they have symptoms from aortic stenosis, it's actually okay to do a stress test. But if the patient already has symptoms, then you shouldn't do a stress test. Uncontrolled heart failure, acute pulmonary embolism, myocarditis, and aortic dissection, these are obvious absolute contraindication for treadmill tests. For a relative contraindication, patient who has moderate valvular heart disease, moderate AS, this is only relative contraindication. Patient who has left main coronary stenosis that has not had revascularization. And if patients really have bad blood pressure to begin with, when you run them on a treadmill, the blood pressure is going to go up more. So that's probably not going to be safe. Patient who had tachyarrhythmia or bradyarrhythmia to begin with. Patient who's not cooperative from mental, physical impairment, it can be dangerous for the patient. This patient fall in this category, difficult EKG, left ventricular hypertrophy with strain pattern, left bundle branch block, or Wolff-Parkinson-White syndrome. Should not do a treadmill test alone, but should be combined with other imaging modalities. Okay, next question. A 46-year-old woman presents with a chief complaint of chest pain on inspiration. She states that the pain on the left side is on the left side is less than when she sits up and leans forward. She has history of chronic renal failure from diabetes and usually undergoes hemodialysis 3 times a week, but has missed her last 4 appointments. On auscultation, there is a scratchy, leathery sound heard during both systole and diastole. The EKG showed diffuse ST segment elevation and PR segment depression. The QRS amplitude is low. Which of the following is the most appropriate next step in this patient's management? A, beta blocker, B, morphine, C, nitroglycerin, D, non-steroidal anti-inflammatory drugs, or D, E, steroids. โหวตเลยค่ะ Wow. Okay. The opinion is really diverging. So, what the pain that she described the pain as more like a pericarditis. So, usually it's relieved by a patient sit up and leaning forward. That's the key. And the risk factor for pericarditis is the chronic renal failure on hemodialysis. So, let's go with the auscultation that shows scratchy, leathery sounds, and the EKG finding that goes along with it. So beta blocker and morphine, nitroglycerin is not going to be useful. That's useful for acute MI. So that leaves with the non-steroidal and on steroid. Obviously, I think that this is a little tricky question because people with renal failure, you want to avoid non-steroidal, but this patient is already on hemodialysis, so it's not going to get any worse than that. So I think the treatment at the beginning for people with acute pericarditis is non-steroidal anti-inflammatory drugs. And patient who has treatment with steroid is also helpful if your patient is allergic to non-steroidal, but it has a high relapse rate. So that should be used thinking about when people had recurrent pericarditis despite non-steroidal anti-inflammatory drugs. Okay, so next question. On routine medical checkup, an 18-year-old man is found to have mid-systolic click followed by a murmur. He's 195 centimeter tall. His arm span is 205 centimeter. His weight is 80 kilogram. Examination shows pectus excavatum, bossing of frontal eminences, and laxity of the ligaments. The thumb can be extended to the wrist. And he said that his father died at the age of 40 because of heart problems. Which of the following is most likely diagnosis? It should be relatively easy. Ehlers-Danlos syndrome, Klinefelter syndrome, Wanpen syndrome, McCune-Albright, or osteogenesis imperfecta. หมดเลยค่ะ All right, good. Very good. So we don't have to talk more about that. So this patient has the features of Wanpen syndrome, which can be associated with the mitral valve prolapse, and that can cause some of the click. Let's see. Let's skip that one. Okay, that one you should know. I'm going to skip that one too. Okay. 35-year-old woman present with moderate hypertension, muscle weakness, polyuria, and paresthesia, and tetanic manifestation. There's no evidence of pitting edema. 24-hour urine test for potassium and free cortisol show loss of potassium and normal levels of free cortisol. CT scan of adrenal glands show a localized encapsulated mass in the left adrenal gland. Which set of the laboratory data would most likely be present in this patient? A, increased aldosterone, increased renin, decreased potassium, increased bicarbonate. B, normal aldosterone, decreased renin, decreased potassium, or increased bicarbonate. And C, increased aldosterone, decreased renin, decreased potassium, and increased bicarbonate. Or E, both renin and aldo are decreased, potassium increased, and bicarbonate is decreased. And C, low aldo, increased renin, increased potassium, and decreased bicarbonate. โหวตเลยค่ะ All right, most people get it right. So this patient have a young woman with hypertension, and the features of muscle weakness and polyuria should think about hypokalemia because you have decreased ability to concentrate urine. And that could be hypoaldosteronism or high cortisolism can cause that feature as well, but they already said that cortisol level is normal. So you should think about, and the CT scan showed adrenal gland nodule, should think about hypoaldosteronism, which usually causes aldosterone to be high, but the renin to be suppressed, and potassium to be low. So the answer is C. Oh, they go back. I just skip that one. Okay. Skip that one too. Okay, we can skip that one. A 25-year-old recently married woman has blood pressure of 145/95 after multiple readings on two separate visits. She smokes 1 pack a day. There's no family history of hypertension. Physical examination is unremarkable, and she's using triphasic oral contraceptive pills. Which of the following is the most likely cause of this patient's hypertension? A, essential hypertension. B, Turner syndrome. C, renal artery fibromuscular dysplasia. D, pheochromocytoma. Or E, iatrogenic etiology. Vote เลยค่ะ Okay, we need to have a little talk. So actually, it's good to think about, obviously this is a young woman with hypertension, so you should think about secondary cause. So essential hypertension would probably not be likely the cause. But oral contraceptive is also a possibility, but that's why I'm sure most people vote that. But with the triphasic oral contraceptives, the chance it's relatively low dose. So actually more common cause in a young woman these days, actually should think about one of the causes in young women is the renal fibromuscular hyperplasia. So it's the most common form of renovascular hypertension in the young adults, and usually involve the distal 2/3 of the artery and affecting a young woman between the age of 15 to 50. And usually it has the typical beaded aneurysmal appearance that usually responded well to angioplasty alone. So it's a little tricky question, but that's what the answer was. Let's see. Okay, I'm going to skip that one. Okay, skip that one. Okay. 65-year-old man with multiple myeloma presents with confusion, severe depression, vomiting, and polyuria. His electrocardiogram shows the following. What is the first step in management? A, give calcium gluconate. B, infuse saline. C, administration of sodium bicarbonate. D, infuse furosemide. Or E, initiation of mitromycin therapy. Bolehค่ะ Wow, okay. Actually, that makes it worse. Okay, so multiple myeloma actually can be complicated by hypercalcemia. So one of the manifestation of complication of multiple myeloma can cause hypercalcemia, which can cause confusion and polyuria from loss of ability to concentrate urine. So this EKG actually show sort of like shortening of QT interval. And so giving calcium is going to make the patient worse. So the first treatment actually to give saline, because polyuria, the patient tend to have decrease in volume, intravascular volume, and when the more volume depletion, there's more calcium absorption from the kidney. So it's not a good idea to give more diuretics. Really, sodium bicarbonate is not helpful because this patient is not hypokalemia kind of problem. So you try to expand the volume first, and there's some other treatment to reduce intercalcium. This is older therapy, but if it's resistant to saline infusion, then you might need to give some of this agent. So the answer is B. Okay. Next question is 60-year-old man complains of pain and numbness in the left leg when walking. The pain is relieved by resting. He also complains of impotence. The physical exams show atrophy of the left leg muscle, normal reflexes and a bruit over the femoral artery. Which of the following is the most likely diagnosis? A, Lurich syndrome. B, herniated lumbar disc. C, osteoarthritis of the hip. D, phlegmocele alba dolens. E, peripheral neuropathy. Boleh kan? All right, good. Very well. It's a big recovery after the last question. So this patient has peripheral arterial disease that if it occurs in the aorta iliac disease, then it can cause only intermittent claudication, but also impotence. And that's combination of intermittent claudication and impotence is from what we call Lurich syndrome. Oops. Okay. So the answer is A. Let's see. I guess we can try this. Next question is a 43-year-old patient with end-stage renal disease that has the following electrocardiogram. For specifically reversing the effects on cardiac muscle in this patient, physician should administer which of the following? A, sodium bicarbonate. B, furosemide. C, calcium gluconate. D, glucose plus insulin. Or E, cation exchange resin. Boleh ka? Okay, good. Now this time you want to give calcium. So patient has EKG finding that consistent with the hyperkalemia, with the peak tau and peak T wave. And although glucose plus insulin and cation exchange resin will reduce serum potassium, but the one that can reverse effects on the cardiac muscle more directly is the calcium gluconate. So that's C is the right answer. Okay, let's see, we can skip that one. Okay, we can talk about this one. 58-year-old man with palpitation and lightheadedness. Which of the following is the most problem associated with this parent? A, congenital heart disease. B, severe aortic valve disease. C, hypokalemia. D, atrial septal defect. Or E, VSD. Boleh kah? Okay. That actually is not the, most people didn't, well, it's not the hypokalemia presentation. Actually, this EKG show more like a left ventricular hypertrophy, almost like a left bundle type of morphology. And so actually that's most likely to reflect the aortic valve disease that associated with the lightheadedness. The hypokalemia, usually you have more prominent U waves. It's not, maybe it's not the prominent feature of this ECG. So actually we should think about aortic valve disease that causes lightheadedness and palpitation in the setting of the left ventricular hypertrophy looking EKG. Okay, well, let's do one more. Metabolic abnormalities. What is a metabolic abnormality that is typical cause of these EKG changes? A, hypokalemia. B, hypercalcemia. C, hypomagnesemia. D, hyperkalemia. Or E, hypocalcemia. Boleh kah? Okay, this time is a hypokalemia. That's not the one before that. So the features we talk about of hypokalemia is prominent U wave and prolonged QT. Not because of, it's because of the U wave that superimposed on the T wave that's make the QT prolonged. But this patient definitely has a prominent U wave, and that's a manifestation of hypokalemia. Okay, you can skip that one. Next question, a positive ECG exercise test for diagnosis of coronary artery disease should show A, tachycardia, bradycardia, C, 1 millimeter flat or downsloping ST, depression, D, normal EKG. Well, no one is going to vote for that, right? And E, absence of U waves. So, boleh kah? Boleh kah? Okay, everyone got it right. So you should look for a flat or downsloping ST segment depression. That's considered to be a positive test. And just to mention that it should be normal. You can have ST depression, but it should be upsloping. ST depression is considered to be normal, but if it's flat or downsloping, that's considered to be abnormal from the J point between 30 to 80 milliseconds, 60 to 80 milliseconds if it's 1 millimeter or more depressed from the J point. That's considered to be abnormal. But upsloping is normal. If it's J point is suppressed, but the segment is upsloping, it's okay. On what basis can diagnosis of malignant hypertension be made? A, level of systolic blood pressure. B, level of diastolic blood pressure. C, headache. D, fundoscopic changes. Or E, heart size. โหวตเลยค่ะโหวตเลยค่ะ Good. So most people get it right. So it's not the level of blood pressure that defines malignant hypertension. It's the presence of acute target organ complication. And the acute is reflected by fundoscopic changes like hemorrhage, exudate, or papilledema. Heart size is if you have enlarged heart, but you don't have heart failure symptoms or signs, it's still not called malignant hypertension. Which of the following findings in the physical examination are compatible with cardiac angina? A, a rise in blood pressure or pulse rate. B, an audible and palpable fourth heart sound. C, increase in anginal pain after Levine test. D, appearance of murmur of mitral regurgitation. E, paradoxical splitting of the second heart sound. โหวตเลยค่ะ Okay, well, it's all spread out. I don't even know there's a Levine test. I never heard of it. I think they make it up, but anyway. There's a Levine sign, but it's no, like patient grabbing the chest like that, but there's no Levine test. Actually, the correct answer is B, audible, palpable fourth heart sound, which the fourth heart sound reflected atrial contraction from decrease in left ventricular compliance. So when you have a cardiac ischemia, you have a stiff ventricle, and then sometimes you have a fourth heart sound, because in order to fill the ventricle, you have to have atrium contraction enough to fill the ventricle. The paradoxical splitting of the second heart sound, it's coming from, it can be observed in patients with the delay in ejection of the left ventricle, such as aortic stenosis or left bundle branch block. But it's not a sign of angina. So answer is B. Okay. Mitral valve prolapse can be described by which of the following statements? A, most affected individuals are asymptomatic. B, men are more affected than women. C, ventricular arrhythmia are common. D, mitral regurgitation frequently develops. Or E, congestive heart failure frequently develops. โหวตเลยค่ะ Frequently develops. Actually, it's okay. It usually does not. Mitral regurgitation is a complication, but it's not frequent. It's more common if it happens in an older patient with causing a degeneration of leaflets. Actually the answer is A. Most people are asymptomatic. Oops, sorry. Yep. Oh, I'm coming back. I think I already give this. Sorry. So most affected women are more affected than men, and most people are asymptomatic. Arrhythmia can happen, but it's not very common. And heart failure, unless you have severe mitral regurgitation, is not very common. So actually, people are diagnosed a lot with that, but most of them are asymptomatic. Okay, I'm going to skip that. Skip that too. Okay, well, this is a little harder, but anyway, just for fun. 71-year-old man presents with cardiogenic shock and acute pulmonary edema. 9 years earlier, he had both of his mitral and aortic valve replaced with the Bjork-Shiley prosthesis. A frame from sinofluoroscopy study show in that figure demonstrate all of the following except A, intact aortic valve prosthesis, B, intact mitral valve prosthesis, C, several minor strut, or E, D, free-floating disc. It's very hard, actually. I can't even believe they have this question in there, but anyway. It's a mechanical heart valve that is most commonly placed a while back. Okay. Wow. 5% of people get it right. Let's see. So this patient actually has a fracture aortic valve prosthesis. Fracture mitral valve prosthesis. And so you can see, I'll probably be better to show that this is what it should look like normally. It's a Bjork-Shiley valve, so you have a major strut and a minor strut, and then the disc in the middle. And when they resign the disc, the minor strut tends to break, and the disc fall out of the patient, and then patient usually have cardiovascular collapse from embolization of the disc, causing the severe valvular regurgitation. And it's a lot. In this patient, it's the mitral valve that dislodged. The aortic valve usually has more superior and more horizontal orientations. But this is the mitral valve. And then this one is a piece of the minor strut. It should be here. And this is the disc that flies out. So it should look like that, but it breaks. Anyway. Which of the following has not been implicated as a clinical complication of sleep apnea? A, heart failure. B, pulmonary hypertension. C, behavioral disorder. D, systemic hypotension. E, nocturnal death. Voteเลยค่ะ Good. So most people get it right. So sleep apnea is now more and more common in patients with obesity. And since we have more obese patients, you should know about what are the complications of sleep apnea, which includes hypertension, not hypotension. And that can also cause pulmonary hypertension and left heart failure mostly from hypertension too. and it can be implicated in sudden cardiac death, nocturnal death. So usually the hypoxia that can cause the can activate the carotid chemoreceptor, and that usually causes sympathetic overactivity to the cause release of norepinephrine and vasoconstriction, and that can lead to high blood pressure. And the treatment is a common cause of resistant hypertension in obese patients, so you should think about that. And because a treatment like weight loss and CPAP can decrease the daytime and nocturnal blood pressure. Let's see, a 35-year-old man is brought to your office because of progressive worsening heart failure. He has hypertrophic cardiomyopathy and ejection fraction of 25%. His creatinine is 2.5, his BUN of 36. He has 2+ edema. His renal function is worsening, and diuretics, despite diuretics and cardiotropic agents. You recommend A, long-term renal dialysis, B, renal transplant, C, cardiac catheterization, D, renal biopsy, or E, heart transplant. โหวตเลยค่ะ Well, it's I guess it's a little different over there and here, but remember this is a U-SMILE test. So this is a young patient with heart failure, and despite maximum medical therapy, his renal function is worsening. So renal dialysis is consideration, but for the young patient, if he's a candidate for transplant, you should think about cardiac transplant. And so the indication for cardiac transplantation is refractory cardiogenic shock, documented dependence on intravenous inotropic support to maintain organ perfusion, or peak oxygen consumption less than 10 mils per kilogram per minute. And severe symptom, patient who has severe symptom of ischemia that limit routine activity that's not amenable for bypass or coronary intervention, or people with recurrent symptomatic ventricular arrhythmia, despite all therapeutic modalities, should be considered to have that. Let's see. All of the following are important in validating someone for appropriateness of this transplant, except A, wealth, B, compliance with medical regimen, C, alcoholism within the last 6 months, D, support network, E, psychiatric evaluation. Boleh. Yeah, it's a little different in medical system in United States. Obviously, not everyone is eligible for transplant, but there will be more concern about the issue of compliance with the regimen and psychiatric history, because that makes patient not compliant with the regimen, or alcoholism, and the patient doesn't have enough support. But actually, wealth is less because at least they have some insurance system over there. So the answer, at least from the U-SMILE perspective, is wealth. Okay. I think I'm going to skip that. Let's see. So while waiting for cardiac transplant, patient developed severe ventricular arrhythmia. You, A, treat his arrhythmia. B, tell the family there's nothing to be done at this point. C, tell them he can only be on experimental drug. D, tell them he cannot receive an experimental drug. Sorry. Or E, tell them he's no longer a transplant candidate. Boleh kah? ค่ะพูดเลย Yes, that's the right answer. So treat the arrhythmia. So as you know, it's actually if your patient has refractory arrhythmia, it's despite all the therapeutic modalities in the setting of heart failure, it's one of the indications for transplant. Okay, let's do this one. 3 years. This is a patient who complained of muscle cramp, numbness, and fatigue in the calf. He's unable to perform normal activities, and the symptoms are more severe on the right compared to the left leg. And now the patient has resting leg pain. Physical examinations show absent pulses below the femoral on the right, and decrease in dorsalis pedis and popliteal-tibialis pulses on the left. Thickened nail beds and dry, cool, smooth, shiny skin with the decrease the hair bilaterally, as well as trace edema bilaterally. An angiogram performed as a diagnostic evaluation is shown in this figure. You suggest all the possible options except A, pentoxifylline 100 milligram TID, B, percutaneous transluminal angioplasty, C, rotational atherectomy, D, intravascular stent, or E, aortofemoral bypass. หมดเลยค่ะ Most people get it right. So this patient have acute limb ischemia probably from thrombosis of underlying peripheral vascular disease. So that's the treatment now should be toward revascularization as soon as possible rather than continue medical therapy. So just to review, patient with peripheral arterial disease, patient could be asymptomatic. Most of the time, patients are not symptomatic. Patient might have intermittent claudication, or patient might have critical limb ischemia, like this patient. If you're not symptomatic, then the treatment should be modifying the risk factor, like stop smoking, control the LDL cholesterol to be below 100, control diabetes, and control blood pressure to the goal, and give antiplatelet treatment, either aspirin or clopidogrel. But you start to have symptoms of intermittent claudication, you do all the risk factor modification just like asymptomatic. But now the treatment for claudication, celostazole, is actually more effective than pentoxifylline in terms of prolonged treadmill walking time. And you should also recommend patient if there's an exercise program that also improves pain-free walking time. And only the patient who doesn't get better with this, that you consider to do angiography followed by revascularization. But if patient already have critical limb ischemia, like this patient, we should think about toward revascularization, either with percutaneous or surgery. Okay.
ต่อสักอีก10 นาทีได้ใช่ไหม
ได้
พี่โรชีเขาจะเตรียมสไลด์อยู่แล้วเดี๋ยวเพิ่งเบรกอยู่ไม่มาเดี๋ยวให้เขาต่อเลย
โอเค
ไหวนะ
ได้ค่ะ 32-year-old baseball player suddenly collapsed during a game. On exam, he's disproportionately tall with long arms and legs, and had mid-systolic click on cardiac auscultation as well as diastolic murmur. His past medical history is significant for severe myopia and multiple joint dislocations. Which of the following is the most likely cause of his syncopal attacks? A, mitral valve prolapse, B, aortic dissection, C, spontaneous pneumothorax, D, pulmonary emboli, E, ventricular arrhythmia. หมดเลยค่ะ Actually, the right answer is B. Although it's true that mitral valve prolapse can be associated with Wanpen syndrome, but usually it doesn't cause, sudden onset of a collapse. So Wanpen syndrome actually is associated with the aortic aneurysm and complicated by dissection. So that actually is the one that explains the cause. So B. Okay, next question. 62-year-old man with hypertension and congestive heart failure presents after suicidal attempt. He has taken 1 bottle of digitalis pills. Of the following possible arrhythmia, all can be seen except A, first-degree AV blocked, B, third-degree AV blocked, C, multifocal atrial tachycardia, D, bidirectional ventricular tachycardia, E, all of the above can be seen. Voleka. Very good, very good. Although only 39 people vote. So actually, digitalis toxicity can cause suppression of atrioventricular conduction, but also increase in automaticity in the atrium. So you can have a combine of heart blocks in the presence of atrial tachycardia, and bidirectional ventricular cardia actually is very specific for digitalis toxicity. So the answers of the above can be seen. Okay, this one is a little hard. Actually, it should be on cardiology board rather than you smile. But anyway, let's go through it. Which of the following is not true? So let's just orientation. So they're showing the EKG, surface EKG, and they show 2 pressure tracing. This one is in the aorta. So it's a pressure that recorded from 2 catheters, one in the aorta and one from the left ventricle. This one is from the left ventricle here. And then there's a PVC, and then this is a post-PVC beat. And they want to ask you which one is not true. A, the first 3 beats show a peak systolic gradient of approximately 25 millimeter mercury. So just to orient it, it is a scale of 50, 100, 50, 200. So the first 3 beats show a peak gradient of approximately 25. So they're talking about this difference between LV pressure and the aortic pressure. On the first sinus beat after the PVC, the peak systolic gradient increased to 100. Is that true? From here to there, it's increased to 100? To over 100. On the first sinus beat after the PVC, the pulse pressure decreases. Or D, the increase in pulse pressure after the PVC results from reduction in stroke volume. And this phenomenon illustrated here is known as the Brockenbrough-Brownwell sign. Voleka. It's not easy. So, actually, it's not too bad. But anyway, so this is actually what we call a Brockenbrough-Brownwell sign that's showing hypertrophic cardiomyopathy. So the first 3 beats of the gradient actually. So the first 3 beat actually has the gradient is about 25. So that's about half of the big block. So that's correct. The first sinus beat after the PVC, peak gradient increase above 100. That's correct. Because this one, that's usually happen when after the PVC, you have more ventricular contraction. Remember, when you have more contraction in the presence of hypertrophic cardiomyopathy, you have more obstruction in the left ventricular outflow tract. So the pulse pressure couldn't decrease. But that's true. They're asking what is not true. So actually what is not true is the D, increasing pulse pressure after premature PVC result from an increase in stroke volume. This should be a decrease in pulse pressure, not increase. But this phenomenon is known as the Brockenbrough-Brown wall sign, from the decrease in pulse pressure from increase in contractility. So the pulse pressure we're talking about here, this pulse pressure is decreased compared to a regular sinus beat. Because of the post-PVC, you have more contraction and you get more obstruction in left ventricular outflow tract. Okay, so the answer is D. So at least 29% of people get it right. มื่อไหร่จบก็ให้บอกพูดไปเลย okay. 70-year-old man with hypertension and diabetes doing well 7 days after suffering for large myocardial infarction. He has not had any conduction disturbance, hypotension, or congestive heart failure. However, on day 8, he becomes severely short of breath and hypotensive. Chest X-ray show a boot-shaped heart that is much larger than previous, and EKG show no ischemic changes, but low voltages. The most likely etiology is A, myocardial rupture, B, papillary muscle rupture, C, flash pulmonary edema, D, pulmonary embolism, or E, sepsis. หมดเลยค่ะ The correct answer is A, myocardial rupture, and the key of that is so this patient obviously has acute myocardial infarction, has a complication, and oops, go back. So the reason is A because although papillary muscle rupture can cause hypotension and heart failure, conduction disturbance, but the chest X-ray that show a boot-shaped heart and EKG that show low voltage, that usually mean the myocardial rupture and causing a cardiac tamponade, and that can cause it's one of the complications of acute MI as well. You are reviewing the intraoperative transesophageal echocardiogram TEE on a 40-year-old female shown below. Based on this study, which one of the clinical manifestations would not be predicted? A, hepatomegaly, B, edema, C, ascites, D, systemic emboli, and E, cyanosis. โหวตเลยค่ะ Okay, so this is a cardiac myxoma, and it's a little bit hard because it's a transesophageal echo. It depends on where the valve is, but this is in the right-sided chamber. So usually in the right-sided chamber, the systemic emboli obviously won't be predicted unless you have atrial septal defect. But anyway, next question: a 35-year-old man presents for elective resection of 5 centimeter infrarenal abdominal aorta, abdominal aortic aneurysm. His past medical history is significant for hypertension, inferior myocardial infarction, and stable angina. Patient also have history of heavy smoking for 15 years. What is the significance for abdominal aortic aneurysm in this preoperative patient? A, the risk of rupture is 20%. B, the probability of rupture without surgery is almost 50%. C, abdominal pain back pain and leg ischemia can be symptom of aneurysm increasing in size. The mortality associated with elective surgery is about 5%, or the mortality rate of repairing a ruptured aneurysm is about 10%. So this question asks you the knowledge about abdominal aortic aneurysm หมดเลยค่ะ โอเคเอาคะแนนสุดท้ายค่ะ Okay, so I guess it's all spread out. So let's talk a little bit about that. So this is the answer is D actually because of the mortality rate of elective surgery is about 5%. This size is not yet the size for repair for abdominal aortic aneurysm. So the indication for repair for abdominal aortic aneurysm is 5.5 centimeter above. So the risk of rupture for a smaller one, like this size of 5 centimeter, is between 5 to 5.4 is about 1% per year. But greater than 5.5, the risk of rupture is about 5% per year. And mortality from elective repair is about 5%. So that's why they recommend repairing it when the risks from rupture start to exceed the risk from elective repair. So the indication for repair is if you document the expansion of aneurysm, obviously a ruptured aneurysm, you need to repair it. Or if you have rapid expansion greater than 1 centimeter per year, even though it's less than 5.5, but if it's growing rapidly, you might consider repair that faster than that. And the size for repairing aneurysm for ascending aorta is about 5, and for non-Marfan syndrome, and more than 4.5 for Marfan syndrome patient. But for abdominal, it's 5.5 or above. So I think we're going to end the cardiovascular review here and so move on to the next session of allergy and immunology. Thank you.
Thank you very much. I was told that this is the most efficient sessions because we are now going through more than 60 questions in this morning. Please also give me a big hand of applause for Dr. Wanpen again, please. We are going to